Okay. Go.
Going. She's just got to do.
Okay, we're going to make a start. Hopefully people will be there and able to hear us now. So good morning, my name is Dr Harriet Conniff and I'm the lead psychologist for staff support at the Evelina London, which is part of Guy's and St Thomas's.
And I'm Dr Berger, consultant clinical psychologist working at Great Ormond Street Hospital.
And this morning we're going to be talking about group interventions, to whether to debrief or not, and how we can offer group interventions in a useful and safe way. And so one of the good things that has come out of the pandemic is a recognition of the importance of supporting healthcare staff to do their job. And this is something that many psychologists working in paediatrics and health have been doing for years. So Zoe and I have been doing this for about 10 to 15 years, and some of our colleagues for much, much longer. It's also important to state that my role existed before COVID, and within that it's really important to recognise and thank the managers, clinicians and systems that have allowed this work to happen and have been supportive of psychologists working to support healthcare staff, because without the backing of the system this work cannot take place. So we will be looking at why we support staff and why we may need to debrief, and then turning to some definitions of debriefs. Then we'll be looking in a bit of detail at the evidence base and touch upon some do's and don'ts in terms of debriefing. Then we'll look at debriefing in the context of COVID-19, and then look at an example of a debrief pathway as part of a system of staff support. And then we'll offer out some ideas about types of group support you can have when you don't have access to a psychologist. And there'll be an opportunity to ask questions or make some reflections at the end. So why do we need to support staff? I think it's important first to state that when we think about providing support to staff in healthcare, both Zoe and I and many psychologists are coming from a position of assuming that staff that work in healthcare are competent and resilient. Nonetheless, we do know that staff well-being has an impact on things like sickness rates and retention, and it also impacts on patient care. So we know this from serious case reviews, and we know this from national reviews, that if staff are well supported, they can be emotionally available to patients and to parents, so they can be containing and more empathic, for instance. And in terms of a pandemic, we can, while we've never been in this position before and this is unprecedented, etc., we know from previous smaller pandemics and from mass trauma and international disaster work that there is a prevalence, we can predict the prevalence of psychological difficulties. So there's evidence that up to half of all healthcare workers will experience some sort of significant acute psychological symptoms during a pandemic, and that these acute symptoms are likely to reach a peak near the end of the pandemic situation, so or after the peak. So we could say that round about now, because we're moving out of the peak, that we're seeing more acute distress reactions. And this may be at a time when some organisations and trusts are beginning to withdraw the wellbeing offer, perhaps understandably, if it's something like a wellbeing zone or a rest and recharge zone, that clinical areas are needed because we're upping clinical activity again. But nonetheless, it's important that we need to still pay attention and offer wellbeing support at this time. And it's important to stress that these reactions are normal and understandable reactions to an abnormal situation. So in terms of future ongoing mental health consequences, we know that 1 in 10 staff are likely to have these, but this does mean that 9 in 10 will not. And the good news is that most reactions with support will subside. And so we know that supporting staff is really crucial, as it's protective of staff developing long-term problems. So this is a slide that NHS England and Improvement put out at the beginning of the pandemic. Some of you may be familiar with it, and I guess it's not, the detail isn't totally important. It talks about different stages of the pandemic and potential negative impacts. But Zoe and I just thought it would be useful to put on some of the main themes that we came across so far. So in that pre-phase, there was definitely lots of anxiety and people were coping with the uncertainty. And many staff were talking about this sense of being on an empty beach with a tsunami wave that they could see was coming, but they didn't know when it was going to hit and how hard it would hit. And then during the kind of main active phase, there was still anxiety and people were coping with uncertainty. But there was also people talking about feeling energized, feeling part of something. Tiredness had begun to kick in. There were definite concerns about PPE and the guidance was changing both nationally and internationally. We also saw lots of staff, including ourselves, talking about how difficult it was when you work in healthcare to switch off from COVID-19. So we know that all the public guidance was to limit the amount of time that you spend looking at the news or on social media. But if you're working in healthcare where you're bombarded with lots of emails at the moment and also multiple meetings and conversations about COVID, and you may be working with patients who have that diagnosis, then how do you escape? And when you go home, how do you unwind when your normal methods of supporting yourself may not be available to you? And at that time, we also began to see frustration and also sorrow and grief, sadly, as people were affected by the death of perhaps loved ones and sadly colleagues as well. And then as we moved out of that peak phase, we began to see more anger, some numbness, people talking in a very detached way, lots more distress. And this was coinciding with teams reforming. Perhaps people were returning from redeployment, and also we're beginning to see now people coming back into the workplace who have been shielding at home. And everybody is talking from a very different place, and people will have had, and they're talking about having very different experiences and different emotional reactions, and sometimes having different emotional reactions and conflicting feelings at the same time. And right now we're definitely seeing lots more exhaustion. And what's to come? Well, we're not really sure what's going to happen next. But I definitely think we're back in an anxious and coping with an uncertainty type phase. That's definitely what we're both seeing more of.
And what about debriefs? Where do debriefs fit in? We've certainly been asked to offer debriefs for one-off events during COVID-19, and there's been a rise in the request for these as we've moved out of the peak phase. But what do we actually mean by a debrief? I don't know about you, I'm kind of curious about what images or ideas get conjured up for you when we use that term. For some, a debrief is a formal meeting that focuses on critical events and the learning that comes from that. And for others, it's just a chance to offload with friends after work, often at the pub, or in pre-COVID days at the pub. And all of the meetings below, many of which you will be familiar with, have a function to review events. So to consider what went well, what was more tricky, but also sometimes to enable some space for reflection for how the events felt to the people that were involved. Psychologically facilitated debriefs are different again. And Harriet and I, along with some colleagues in Bristol and Leeds, have just written a paper about group interventions that goes into much more detail about the differences between these different meetings. But I suppose what we're trying to say is that in our experience, a team, when they ask for a debrief, will want very different things depending on who's requesting it and in what context. And it's this real lack of clarity about what we mean when we say a debrief that's made it really hard over the years to be certain of the model, the evidence base, and who's therefore best placed to deliver them. We know that across an organisation, from our experience, that there's very different emotional responses or reactions to the term having a debrief. It's really not very, it's kind of quite common for us to be greeted with a mixture of both dread and relief at the thought of a debrief being set up around a critical event. And there are very different views about the timing of when these should be offered and if they should be enforced or voluntary. I thought it would be helpful, we both thought it would be helpful to kind of share a little bit about the history of debriefs, so a little bit about the debate that surrounded them for such a long time, because I think that's kind of helpful context. So we know that the concept of debriefs have its roots in the military and first recognised in 1944 by an army historian. And the concept was further expanded on by an American psychologist in 1983, and he coined the term critical incident stress debriefing. And really this was used for emergency services personnel as one part of a much bigger stress management programme. And in the 1980s, debriefing was really very widely adopted in a range of organisations, both commercial and within the NHS, after critical events. And they were used both in group settings and in individual contexts. And when they were first formed, this idea about critical incident debriefing, it was very much believed that they could prevent the development of post-traumatic stress disorder, or PTSD. And research around that time, so sort of research in the 1980s or 90s, began to call into question the effectiveness of debriefing to prevent PTSD. And in fact, some research suggested that it could do harm. And this has really sparked a debate that's continued for a number of years. In 2005, NICE guidance stated that compulsory debriefing should cease. And that's because the early research had tended to focus on the use of debriefing, as I've said, to kind of prevent PTSD. But there were also problems with the early systematic reviews that NICE based its guidance on. And and since then, the evidence that's been used in those reviews have been refuted. So an example of that is that the research was based on some individuals who'd been involved in some road traffic accidents, for example, were put into groups. And so that led, understandably, to an increased incidence of re-traumatizing. So it's this lack of kind of clarity about what the term refers to, combined with the early reviews, meant that many mental health professionals, including psychologists, felt that they should sort of avoid debriefing totally in any form following an event within hospitals. I think we've moved forward from then. We're in a much better place. I think we've got a more nuanced understanding of the evidence now, and we're clearer about the model and who should be delivering it. So we know that there's some good evidence of debriefs in prime populations. So what we mean by that is emergency responders, so people who know or anticipate that there may be a traumatic incident in their work environment. And so there's some good evidence of debriefs being helpful in that population. So we could extrapolate that that will also be useful in some areas of healthcare. A meta-analysis that was published in 2000 identified that social support was the biggest predictor of coping, and Hobfell in 2007 suggested that instead of one particular model, there were in fact 5 key elements that were really useful and should be present and are essential in ensuring the efficacy of a debrief. The most recent review of early interventions in mass trauma, which was published by Richins in 2019, has suggested that there's an important role for group interventions after difficult events for staff that work in highly demanding contexts like healthcare. And the most significant benefits from the intervention come when debriefing is part of a broader programme of support, and we're going to talk about that in much more detail later. And the interventions need to be delivered by someone who's familiar with the worker's role. That really enhances engagement. So we would be coming from a position of recommending that debriefs are led by psychologists or mental health practitioners who are embedded in their teams. There's also much more agreement now in the literature that some will still develop PTSD with or without intervention. So where are we when we think about psychological debriefs? We're clearer on what we mean. We have a better understanding of the issues and of the evidence base. So when we're talking about a psychological debrief, we're talking about a model for group intervention or input following a difficult event that allows staff to gain support from their peers. And the primary purpose is not to prevent PTSD, or to ensure that learning is embedded, but to bring professionals together to build a sense of connection driven by the recognition of shared experiences and values. And the types of debriefs can be used after a specific event or at any time a staff team identify a need to come together and consider the impact of shared experiences on one another. So some good examples of this might be after the death of a patient or a staff member, a serious case review or a near miss, some conflict resolution issues that might evolve. And in the context of COVID, returning from redeployment. Really any event that has a stressful impact sufficient enough to kind of overwhelm the usually effective coping strategies of an individual. So we just wanted to think a little bit with you about what a debrief might look like, to share sort of a framework, a proposed framework for how to conduct a meeting of this nature. So really thinking about the importance of the setup, beginning well, really, setting up the session well, introducing the structure of the meeting and how long it will run for. And depending on the reason of the debrief, it may be helpful to spend the majority of the session supporting staff to tell the story of the event. So really taking care not to encourage reprocessing, so not to invite detailed sensory descriptions of what happened, but really rather support staff to build a shared narrative of what happened, to focus on putting together the pieces. And for many staff, that'd be hugely beneficial. You can also offer some brief psychoeducation about common responses to trauma and to anxiety. And while some people might want to consider some learning outcomes, eliciting the learning points isn't the main aim of the meeting, but we do recognise, and it's often the case for us, that there are some actions that need to be taken outside of the meeting to move things forward. And throughout a debrief, the facilitators need to use their psychological training to draw out narratives of hope, of connectivity to one another, and ensuring that people are feeling like they can work in accordance with their team or individual values. It's also the role of the facilitator to manage quite dominant voices or difficult group dynamics that might be impacting on the psychological safety of the space, and managing high levels of distress, recognising, for example, when it might be important to signpost on to more specialist support. And it's really important to remember that attendance and contribution to the meeting is voluntary. And thinking about when we offer debriefs in the context of COVID, I think there's some additional considerations for running these debriefs at the moment, and this is something that we might pick up in the discussion afterwards. But we've certainly found it helpful to have more than one facilitator, certainly one being a mental health practitioner or a psychologist. And considering the pros and cons of offering these meetings face-to-face or over Zoom. And we've had some really interesting conversations about this. So for some, running a debrief on Zoom has enabled them to access meetings that they otherwise wouldn't have been able to attend. And we've had a much far wider reach on Zoom. But for others, it's been really very difficult to have these quite emotional meetings in their own personal space, at home, away from work, or on their day off. And it's been particularly difficult when we found ourselves in situations where we've got some of the team on Zoom and some on the ward, for example, being socially distanced. And on these occasions, how we've managed that is to have two facilitators, one that's on Zoom, helping to support or create psychological safety for those that are on Zoom on that platform, and the other in the room, enabling the psychological safety to be created and maintained in the room. And we also recognise, as Harriet was saying earlier on, that we're at a stage where people are beginning to notice the differences in their experiences during COVID. And we're recognising that within debrief, very polarising narratives can be very difficult to hear. People who might have had different or opposite experiences to those that they're listening to can make it quite difficult to find a way into talking in those meetings. We also recognise that during COVID, access to other interventions like one-to-ones, rest, space to relax and unwind from the busyness, time with colleagues, for example, might be much more appropriate than attending a debrief. We're wanting to ensure that these are not just single sessions, but as part of a system of care. And that's really important. Harriet's going to say more about that now.
So It is really important that we offer any of the psychological well-being sessions or any of the debriefs don't just exist in isolation. There needs to be a stepped care approach as part of a system of staff support. So you can't just offer some well-being sessions without having referral pathways to occupational health or staff support psychology if you have that. Otherwise, you definitely need to have some signposting to more specialist support, such as adult mental health contacts. You need to have those in order to step up provision of care if needed, and step down as well. And so I thought it'd be useful to talk a bit about the system of staff support that was developed pre-COVID and that we are offering in the Evelina. Which is part of a universal culture of support that we are working towards in line with our values, and very much thinking from a perspective of anti-stigma and discrimination as part of our trust and Evelina values. And this starts at the base of the triangle with things that are more proactive and preventative to promote reflective learning. So that includes interventions in induction and in training. So we're lucky to have at the Evelina the medical mediation team that do training in conflict resolution, and also we would include here ethics training and training on communication. So many of these things don't necessarily involve psychologists delivering these, but they might be psychologically informed. So we'd include in the base of the triangle things like Schwartz rounds and regular staff support meetings, such as reflective practice. And then moving up into more targeted responses. So here we would include MDT case discussions and what some psychologists now are calling pre-brief meetings, which are things that are similar to debriefs, but they don't need a particular incident and they're not following a particular incident. So these would include group support for things like conflict and also for, say, when there's a long stay patient on the ward. And again, as I've mentioned, we have the mediation team, part of them, who provide input mediation between staff and families, but also between different staff groups. And psychology staff support works alongside the mediation team often. And then we might also include in this part of the triangle the case discussions facilitated by psychologists. And in the top, we're thinking about things that are much more reactive to specific events. And that is a little bit of detail there about our debrief pathway, which I will turn to now. So our pathway has 3 stages. So we have an immediate huddle, which I'll talk about in more detail in the next slide. And that can occur either immediately after, say, a crash call, or it might occur at the end of shift. And in that, names are taken so that people can be followed up within 48 hours by their line managers or supervisors. And that could involve something as simple as just a check-in when they're seen at work, how are you? Or it might be an email or a phone call. And in between those 2 first stages, a decision is made as to whether a psychology facilitated debrief is offered or not. So this immediate huddle, so in some areas this might be called a hot debrief, and often in the Evelina people still call it that. So psychologists are not present at that, and this part of the pathway has been developed with the MDT, so including senior clinicians who are part of a working group for staff support, and that included senior nurses, the medical director, and paediatric nurse practitioners, as well as the medical mediation team. So it's important to try and invite all that were involved to meet together, and really people must avoid discussion of performance or opinion or analysis. And the focus is really on what went well and addressing any immediate concerns, such as perhaps there are drug errors or any other kind of risk elements that need to be followed up. There's also a process where people can get support for filling out any paperwork, because sometimes junior doctors or nurses or other professionals may not have done this process before. So it's important within that to identify anyone who might need some support with the paperwork. And the key thing in the immediate huddle is to check in that everyone is all right and to take those names so that people can then be followed up. So we thought we would now kind of just think about together just some possible alternatives to debriefs if you don't have psychologists on site. So we were really thinking about joining, first of all, pre-existing support structures and groupings. So those might range from supervision, business meetings even, huddles, Schwartz, away days, or they could be more peer-based. So we were just talking about how some of these peer-based interventions we're piloting in both the hospitals that we work in. And I guess they could also be specific to the pandemic. And some examples of these might be regrouping sessions from people either returning from shielding to the workplace, or returning from redeployment, or for being in different roles. And includes feedback sessions and also training for managers in how to support staff. But the key thing to remember again is you do need to be prepared for a stepped care approach if you are offering things without psychologists. You need to have signposting in place for more specialist support. And that's the end of our presentation. So now we would invite any comments or questions. Because this is being live streamed, we can't see who's attending, but we have got Kate and Harriet, the other Harriet, who will be fielding any questions via some clever wizardry. So thank you for listening. Okay, so I think we're hoping that Kate or Harriet will rejoin the conversation, and we'll share some of any questions if there are any.
Yeah.